Well, good morning, everyone. Hello, and welcome to Smile Train's Grand Rounds. My name is Darcy Abrams. I am the Manager of Research and Education here at our global headquarters in New York City. We are very, very excited to have you all with us for today's discussion, just quality outcomes in cleft care, integrating surgical, functional, and experiential outcomes. This is a very timely and important topic, and we have a wonderful panel of experts to lead the session today. I do want to thank Smile Train leadership and our regional teams for their support in establishing this collaborative space for our partners across the globe. We have over 300 partners joining us today. Please feel free to drop your location into the chat so we can see where everyone is from. As a reminder, please remain respectful of your fellow participants. We represent a wide range of experiences and settings, and we're all here to learn and improve the quality of the care that we provide. Next slide. Ooh, Zimbabwe, India, fantastic. To ensure that everyone can participate, we have live audio interpretation available in Spanish, Portuguese, and French. Next slide, please. To access these live interpretations, please click the interpretation icon at the bottom of your screen or under the More button if you're on a mobile device, and choose your preferred language from the three. Live translated captions are also available under the Captions link, and we'll drop detailed instructions for both features into the chat now, so you know how to access. Our session today will begin with an academic presentation, followed by a panel discussion, and we will then open the floor for your questions. If you have a question, please type this into the Q&A box at the bottom at any time, and we'll be sure to address them at that portion of the session. And now I am pleased to introduce our facilitator, Dr. Felicity Mahendele. Dr. Mahendele is a plastic, reconstructive, and cleft surgeon, a faculty member at the University of Edinburgh, a member of the Smile Train Medical Advisory Board, and serves as chair of our Smile Train Research and Innovations Advisory Council. We are very thankful to have her joining us today. And with that, Dr. Mahendele, I turn it over to you.
Thank you, Darcy, and the whole team who've put this together. Big welcome to everyone. It's wonderful to see in the chat everyone from so many countries and across many, many time zones. We've got some fantastic speakers and a great panel discussion ahead. But before we go there, just a quick Zoom poll to find out a little bit more about you and your current practice. So if you answer all the questions, and then we'll share the responses later. And I should add, all the polls are anonymous, so feel free to say exactly what you think. So there are 5 questions here. You need to scroll down to see all 5.
We have 20 people who have submitted so far. Great, keep going. Fantastic. I'll give it a few more minutes, more seconds, I should say. Great. Good, good, keep it coming.
Good to see the answers coming in. Looking forward to hearing what you all have to say, or seeing what you all have to say.
All right. Fantastic. Okay, great. I'm going to go ahead and end this, and we should be able to share the results. Perfect.
Okay, so we've got a lot of surgeons, speech pathologists. Great to see psychologists and nutrition providers too. Oh, wonderful. We've got patients as well and family and caregivers. And I think we move on to the next response.
So the next question is, how many patients with clefts do you treat per month? We have a lot who are reporting 0 to 10, and then going down the list, 11 to 20, 21 to 30, and then 31. Do you currently use patient-reported outcome measures at your treatment center? We are split right down the middle, 50-50, saying yes, they do, and no, they don't. What outcome domains are routinely assessed in your Cleft program? We have surgical, with about 82% of respondents saying surgical outcomes are reported. Dental, 37%, speech, 47%, and then nutrition, psychosocial, and patient experience all hovering at around the 25%. And then lastly, what perspective is most often missing when assessing the success of Cleft care? The majority of people say that that would be family and caregiver, coming in at 50%, with the patient at 38%, and oral health and feeding at 40%. Speech and surgeon was represented strongly. All right, fantastic. Thank you.
Thank you, Darcy. So I'm going to briefly introduce our 4 speakers. The first is Dr. Aparna V.S., who holds a PhD in speech-language pathology and has over 15 years of experience in the management of individuals with clefts. She contributed to the development of standardized VPD assessment protocols, has published in international peer-reviewed journals, and served on scientific committees for professional conferences. She is an executive committee member of the Indian Cleft Lip, Palate and Craniofacial Association and is the lead speech-language pathologist at the Smile Train Cleft Leadership Centre, Bhagwan Mahavir Jain Hospital in Bangalore, India. Our second speaker is Dr. Krishnamurthy Bonanthaya. He is a maxillofacial surgeon specializing in cleft lip and palate. He served as project director for the Smile Train supported Cleft Leadership Centre, Bhagwan Mahavir Jain Hospital from 2005 to 2023, where his team performed over 10,000 procedures. He is a professor of maxillofacial surgery, contributes to clinical research, and has held presidencies for major organizations, including the Indian Cleft Lip Palate Craniofacial Association and the Association of Oral and Maxillofacial Surgeons. He chairs the Indian Medical Advisory Council for Smile Train and is a member of Smile Train's Research and Innovation Advisory Council. Next, we have Dr. Mariani Hibas, who is also a PhD in speech and language therapy, processes and disorders of communication. She has a master's degree in learning and development psychology and postgraduate training in health psychology and neuropsychology. She serves as a psychologist at the Hospital for Rehabilitation of Craniofacial Anomalies and the Bauru Medical School at the University of Sao Paulo, and is a psychosocial advisor for Smile Train Brazil. Dr. Percy Rossell Perry is a plastic and reconstructive surgeon specializing in cleft lip and palate. He is a fellow of the American College of Surgeons and holds a PhD in clinical research. He is a research professor at the Health Sciences faculty at Peruvian Union University and serves as a plastic surgery assistant at the Edgardo Rebagliati Martins Hospital in Lima, Peru. He has developed innovative surgical techniques, authored medical textbooks, and currently serves on both Smile Train's Research and Innovation Advisory Council and Smile Train's Latin America Medical Advisory Council. So over to the 4 speakers now.
Sorry, I was muted. Can you hear me, Felicity?
Yes, I can.
Yeah, thank you very much, Felicity, for getting us going in this grand rounds. At the very outset, I would like to thank Smile Train for giving me this privilege to be talking about my concepts of quality in surgical care, and so on. We rarely get an opportunity to speak to a worldwide audience, even when we go to a Cleft meeting, because we are all divided into tens of rooms there. And this is a great opportunity. I hope you will enjoy it as much as I'm hoping to do. Before I actually starting about quality in cleft care, I want to set this whole grand rounds in a context. The very fact that we from so many LMIC countries are even sitting here and discussing quality of cleft care, patient experiences, integrating function with surgical results is a great tribute to this organization that has helped manage, treat, take care of millions of children born with cleft lip and palate around the world. I'm talking about Smile Train. I've been working with them for 25 years. The very fact that from a time when we used to operate primary cases at 11 or 12 years of age on an average, that we are today able to follow protocols that are prescribed worldwide, that we are talking about achieving the kind of results that can be obtained anywhere globally with this model is a wonderful tribute. And I'm sure all of you will join me in congratulating Smile Train on this phenomenal game-changing work that they have carried out in the last close to 3 decades now. Also, I would like to thank Darcy and her team who have made meticulous arrangements to make this complex process of this grand rounds run smoothly. We can't thank them enough. But talking about quality in cleft care, the slide says rethinking. Why do we have to rethink? Did we always not think of quality? Always we did that. But each one of us in different circumstances at different times looked at it from a different perspective. And what I'm trying to say now is that if you have to decide that your treatment has been successful, it has got to be measured by the overall well-being of the child and their family, and not with individual team members, technical successes or otherwise. Can we go to the next slide, Chelsea? I'll just give you an example. You look at this kid. You see him growing up in this picture from 3 years to 7 years to he's almost 14. The first picture was taken by one of the famous photographers who visited us from New York, and I think has been used in some of our posters. I see more than 50% of your surgeons in this group, and you will all agree that the results that we have obtained, one of my colleagues has obtained in this case, has stood the test of time. He appears to be growing very well, and he's smart, not much of a stigmata on his face. And if I were to project this in a cleft conference and say, these are how my cleft lips appear, these are very successful, there won't be much dispute. But is that all behind this kid? Let's go to the next one, Chelsea. He came to us about 14 years ago, like that, on the left-hand side corner. Every single part of his body was devoid of any fat, whether it was the face, the chest, the axillary area, the groin, or whatever. And he has lost about 1 kg from the time he was born. And the simple problem here was the mother did not know how to feed. There were no other issues at all. From time to time, I'm sure some of you, at least in some parts of the world, see these patients. The cleft takes a back seat, even though it has caused this problem. And as you can see, in a period of about 5 months, we have nursed him into a nice, chubby little boy who should now be ready for surgery. From 2 kg to 6 kg, all we did was admit him with his mother, showed her how to feed. This is what our pediatricians did. And when you see him at 15 years, you don't see what he has gone through. Also, there is a part of the story which is not visible here. This kid who looks so smart had a VPD. I operated on him. It did not work very well. We did a second surgery to improve his VPD, where now he has got a good movement of his palate and closure. However, even today, his speech is not up to the mark. One of the problems he has, as our psychologist worked with him, is that he has cognitive and learning disabilities, and we are trying our best to integrate him into the society so that he can be completely functional. So the basic point here is that we need to look for the complete well-being as a barometer for success. And this can come about only if we work as a team. This is something that I've learned over 20 odd years working, trying to build a team which initially had just 2 surgeons to a place now which has, in addition to the initial 2 surgeons, 3 surgeons, 2 speech and language pathologists, 3 orthodontists, 1 nutritionist, 1 pediatric dentist, 1 psychologist, and so on, who are part of our team, where everybody pitches in at the right time, keeps the problems of the patient in mind, most of the times, I should say, and then tries to get result. Next slide, please, Chelsea. I'll just give you another example of how quality evolves from a caregiver's perspective. Like I mentioned in the beginning, when we started working with SmileTrain, there was a huge backlog of patients. All we did was try to do surgeries. The team consisted initially in most parts of the world, most parts of a place where I come from, of surgeons trying to do as many surgeries as was possible. There was neither the time to look at your outcomes, nor was it possible to obtain the best outcomes when you're operating on people who are 10 or 15 or 20 years of age. You will all agree with me. However, that was obviously something like filling up holes. We fill up a lot of potholes in many of our roads. It's just like that. It doesn't work patchwork. You need to have something more than that. And that's when, over a period of time, we slowly developed a speech pathology support, initially referring patients to a nearby institute and then having them come over to us once in a while, to Aparna joining us about 12 years ago, full-time, providing Cleft care every day of the year that she worked, and now having another trained speech and language pathologist. We learned a lot. We learned as surgeons when our results were good, when our results were not going according to plan. And then we also realized that we are creating a number of patients in whom we have not restored the function completely, who had velopharyngeal dysfunction. We had little evidence, little knowledge, less skills to come to a conclusion in the beginning when we started treating these patients as to how we could get good results. But we audited our results as we continued doing a particular procedure, commonly for our VPD. Next slide, please. And looked at it very carefully. And then this is being published in the Cleft Palate Craniofacial Journal. In our hands, Furlow's palatoplasty was working. In many instances, it was not working. In some of the instances, we looked at the outcomes that could predict to us before we did the surgery as to what are the preoperative requirements where Furlow's palatoplasty would be successful in the management of VPD and where it would not. And this paper produced a mathematical formula which gave us an algorithm to decide what to do with the VPD patient, either to do a Furlow's or add on a pharyngeal flap, a technique called suspension palatoplasty, which is something that has been recently described by one of our senior colleagues, Dr. Reddy from Hyderabad. He's published it in the Cleft Palate Craniofacial Journal. And now we have our own experience of putting this algorithm to place, making sure we use not only the teamwork between the surgeon and the speech therapist, but also some objective criteria to decide what surgery we want to do. And this is now awaiting publication. We are waiting. It says editorial decision pending on this. We have jumped a few hoops to get this published. But the point I'm making here is that it would have been impossible for us as surgeons working alone. Many times we think that our great skills can cross any barrier, can get the best results for people, but it will not happen universally. It's a very simple fact, but it needs to be reinforced that you need to work with your team members, identifying the problems, looking for solutions that work for you, and making sure that the solution you have devised works by auditing those results, publishing them so that your experiences help others as well. That is one message I want to give you. Work as a team. Every member of the team is important. They add value. it is the total output is not equal to the sum of the parts. It is greater than the sum of the parts. And this is something you can only experience when you work with this team. My next slide, please. The last thing that I want to speak about is surgical quality outcomes. Chelsea, can I have the next slide? Yeah. So we all know, I think Percy is going to talk about, go back. Percy is going to go back, Chelsea, sorry. Percy is going to talk about these things, but we have all kinds of traditional surgical quality outcomes. You have complication rates, revision rates, fistula rates, speech surgery. These are useful. It helps us to compare, it helps us to know what is the standard set, etc. However, there are two important challenges that I want to talk about. I hope we can discuss this more during the panel. One is that the criteria for measuring these outcomes are still nebulous. I'll just give you two examples. Somebody's fistula may be another person's residual cleft. Somebody's velopharyngeal dysfunction may be normal speech for another person, because there are so much of variation, there is so much of heterogeneity in trying to come to an agreement with this. And more importantly, this is something that is a part of today's theme of parental outcomes. We are now going to look at outcome measurements which are reported by the parents and not by the patients. We will discuss this in greater detail. Thank you very much. We'll move on to the next segment. Next slide, Chelsea.
Okay, good morning. This is my time, I think. I will be ready to start. Can you hear me?
Yes, sir.
Yeah, can you hear me? Perfect. So,
yes.
Okay. So, thank you for the opportunity to be here discussing this important topic. And during this presentation, I like to provide some tips to be used for discussion later during this morning. And the outcome assessment is related to many points, many things. As I presenting here in this slide, can you see that the severity of the problem of the cleft is extremely important to understand how the outcome is good or not. Also, the follow-up during the time to see how the patient is going, to understand the quality of the outcome. Also, we need standard. The measurements should be standardized. It is difficult to compare outcomes or to evaluate outcomes without standard measurements. In that way, instruments are also important, validate instruments, and also the development of clinical research is another important point to evaluate in adequate way the quality. Next slide, please. This is just an example, okay? This is just an example. This is a diagram we use to measure the problem at birth. This is the clock diagram. The clock diagram has 4 segments, as you see here in color. Each segment is related to each component of the cleft. In case of unilateral cleft lip, for an example, the nasal component, labial, primary palate, and also secondary palate. So after using this diagram, we may have a simple way to have a diagnostic. I understand that the problem is more complex, in fact. There are other components, but we may start including the main ones. And we are using this diagram to elaborate a diagnostic of the severity of the cleft at birth. Next, please. This is an example. You have a picture here, the cleft lip and the cleft palate, and we have 3 degrees of severity on each component, mild, moderate, and severe, and 3 degrees of severity for each component. And then we have a cleft code. with 4 numbers. It's very easy for communication between the team, because with 4 numbers, we have an idea of the severity of the cleft and can be used for communication and, of course, to apply a proper protocol of treatment. Next, please. This is the 4th component related to the palate. This is an index of the palate between the width of the cleft segments and the width of the cleft. This is a simple proportion. Of course, cleft palate is more complex, but we understand in our experience, and also we studied, you have the reference here, you may review the paper, we studied the validity of these instruments to be used to evaluate cleft palate severity. And we cannot talk about outcome without a proper diagnostic in special severity of the cleft. Next, please. Okay, this is important. This is a lifetime line of patient, and we believe that there are critical points to be evaluated during the time life of the patient. Critical points. The first one is at the time of lip repair. At the time of lip repair, 3 to 6 months is the best time to address, to evaluate and measure cleft severity, because we have the baby under general anesthesia. Babies, children, they do not collaborate with any measurement, any evaluation. It's difficult to get collaboration from children. So the best time to get information is when we perform the procedures, the interventions. First one, cleft lip surgery, 3 to 6 months, is the best time to evaluate severity. Second time, palate surgery. We may evaluate palate surgery, and also we may evaluate at the second time the outcome of the first intervention, lip and nose surgery. Next point, 5 years. We use this time because in our protocol, we are closing first the alveolar cleft at that time, 5 years. So we can evaluate lip and palate outcome because baby, children is under general anesthesia. We may use different instruments as you consider. There are many ways to do that, to evaluate the outcome in an objective way. Next time, alveolar bone graft. Also, we have another chance. Children is under anesthesia. We can obtain a lot of information to be used, and also, very important, standardized information. This is extremely important. Finally, 16 to 18 years old for final refinements or maybe orthonative surgery. Patient is not a children, patient is an adult, and he can collaborate with any objective measurement to get information about quality of the treatment. Okay, next one, please. This is our traffic light method. This is a way to understand how the center is performing. You can see different intervention, different times, the 3 to 6 months, 9 to 12 months, alveolar bone graft time, then adult, and then you have any A1, AB, as I mentioned before, different measurements, and we have 3 degrees of quality, mild, moderate, or good, or mild, or bad, okay? And we may have an information about how the center is performing during the time. And also, we may have information about the follow-up, which is very important. We are not only evaluating the quality outcome of the intervention, speech therapy, surgery, dental. Also, we are evaluating center performance during the time. What is happening if the center is only following 30% of the patients with low number of information about quality? What about a center with 90% of follow-up? So this is important because we may develop a plan, a specific plan for any center, also for any patient, also for any type of intervention. Maybe they have problem with the speech, maybe they have problem with dental or surgery. Next one, please. I understand the time is short. You can see here different ways to evaluate standardized photos for cleft lip and nose. In palate, we may evaluate anatomic assessment for fistula, wound healings, also functional outcomes, speech, feeding. For orthodontics and oral health, we may include standardized photos, malocclusion, and also during the time Cleft Q as one instrument. There are many of them. Speech the same. At the 5 years old, we are using the nasal endoscopy, also phonoaudiologic evaluation, fluoroscopy are used, and the velar closure radio is an important way to evaluate function. Adult, we may consider Cleft Q as one of the instrument used, and also in psychology, there are many ways to be evaluated, but the important point is that they should be standardized and validated also. Next one, please. Okay, and I think I don't have here one slide showing we did a research about the use of deep learning models. This is not the future. We are living in the future. So using the artificial intelligence, we may evaluate in a standardized way all cases. Actually, we are randomly evaluating the quality, but this is not the perfect way to do that because we are losing information. I think actually we have instruments developed by artificial intelligence to evaluate all the cases in a standardized way. And there is a publication, probably we may share the link, and you can read it about that. We develop it. There are many publications regarding that topic. And also, finally, just because the time is very short, we have to consider which is the standard. Because maybe we may accept that a mild or moderate quality of outcome will be acceptable. But I understand SmileTrain wants the best outcomes possible to be achieved. In that way, it's important to get standards. How is the quality of the outcome that we want to have in our centers? And based in the evaluation of the outcome, we may proceed with the training of the centers based on their needs. This is extremely important. We want these outcomes in nose in all patients. Can be possible? Of course, it is possible to do that. But we have to know first the quality of the outcome in each center. Next, please. I think that's it. Thank you for the opportunity.
Thank you, Dr. Percy. So from Dr. Krishnamurthy, we heard how quality has evolved over time in cleft care, and how from Dr. Percy that how surgical outcome remains fundamental. But we also know that that's not it. We don't treat only cleft, we have to treat the patient. Next slide. So when we look into the outcomes, after the surgery is done, we want the child to speak, eat, have a good aesthetics, and perform well in the society, participate well in the society, to know that the purpose is served, and we have reached where we are supposed to be. So when we do that, there are different domains. So this comprehensive cleft care wheel represent different domains which we need to look into during the cleft care continuum. So when we do this, there is this wheel represent that This is not a treatment one after the other, but we are looking into these treatments simultaneously, and these are interconnected. When we measure outcomes, we can't be looking only at the symptoms. We also need to understand there are standardized ways of reporting these outcomes, which could be compared over time. And eventually, we know that when the care ends. Next slide. So when you look in the outcome domains, so we know that we want the child to speak properly, and when they are speaking properly, you need to be hearing, should not be hearing any errors in articulation. The speech clarity should be normal. Uh, and how does it present in a normal cleft care setup? So it presents as hypernasality, or the clarity of speech getting affected. So when we are reporting these outcomes, we need to have a standardized protocol for doing it. So these are some of the protocols which we use in our center, which we have put up, but then there are many which will vary across centers or across regions. This is going to give a complete representation of how the cleft speech would look like to an evaluator who is looking into the quality of care which we are providing in terms of surgery or in terms of therapy. And the next domain is feeding, where we are looking into if the child is growing adequately. The clinical presentation could be the height, the weight, how much the child is feeding per meal, and if there is a safe airway for the child to coordinate feeding, which can be presented in some of the cases where there can be coexisting symptoms. Um, in those cases, a nutritionist or a speech pathologist who could assist the nutritionist to find out if the child is growing properly in terms of growth charts, or there are scales which could use to see if the feeding is appropriate, the child is being able to take in adequately to grow well. And if there is any feeding issues in terms of coordination, etc., you can have an instrumental assessments which could be done like a video fluoroscopy, a barium swallow study, or a FEES. Dental and orthodontic. So you start from dental hygiene. When children grow up, they can have a lot of cavities. So this has been established that children with cleft, especially because of their occlusal problems, the poor hygiene, where the parents would don't know how to maintain their hygiene when the teeth is different. So all of those contribute to dental hygiene issues, as well as occlusion and arch relationship, which will affect, in fact, their facial growth later. And there are scales like Gosling yardstick. You look at the craniofacial growth, and there are dental hygiene scales which could be used to report the outcome when it comes to dental and orthodontic. Hearing, 60% of children with cleft are reported to have middle ear dysfunction, most of the time missed out. And when you look into this, the clinical presentation can be ear pain, there's oozing out from the ear, there can be reduced hearing acuity. And a ENT would do a visual otoscopy. The audiologist can do a tympanometry or pure tone audiometry to establish if there is a middle ear dysfunction, and in turn a hearing loss in these children, which could also be reported as an outcome. Psychosocial can present as varied things, like the main thing what we see is a self-esteem or self-image motivations, but it can also present as learning difficulties, poor academic performance. So you look into scales like patient reported outcomes to understand this, but there are separate tests which can be used for all these categories, which is not cleft specific, but the psychologist can decide which test to administer and report the psychosocial outcomes accordingly. Next slide, please. So when you have children presenting to your clinic, and when you have a multidisciplinary team working together to understand the child as a whole, then you put across the across the outcomes in different domains, which gives a complete picture of the child. So you are in turn looking into if your child, this child is going to be functionally and participating well in the society. And if I want to show an example of 11-year-old who is a bilateral cleft lip and palate, you presented at 11 years, speech difficulty was there, so there was a VPD surgery done. And here the hypernasality is not there now, the voice is normal, but speech is still not understandable. There is acceptability issues. The speech is not completely acceptable to a normal society, which can in turn affect his self-esteem and confidence. There are errors, articulation errors, which can look like some related to learning, some related to his dentition. When a orthodontist look into this, and they found that the score is Gosselin 4, and then also child says there's an ear pain, so then you find out that there is a beta tympanogram, there's otitis media, which can in fact contribute to the speech problems as well. Then there is this child also, the parent also saying that, oh, he's poor in academics, and then you see that his learning is also poor when you provide therapy. Then further, a psychologist looks into it, found that there is a learning disability in this kid. So all these put together, you are seeing the child as a whole and not as one particular area, cleft alone or a teeth alone, etc. Next slide, please. So, okay.
So, first, I'd like to thank you for the invitation and the opportunity to share about our work in Brazil. What experiences do patients and parents report? Next, please. When we talk about quality cleft care, we have to emphasize the importance of longitudinal follow-up. At Centrinho, we support people with cleft from birth until the end of their rehabilitation journey. At birth, we usually help families cope with the cleft diagnosis, feeding adaptations, and the first surgical procedures. For example, some parents say, I ask myself what I did for my child to be born with a cleft. Some parents feel that they are responsible for the cleft. Therefore, it's important to validate their feelings and provide the proper guidance because families need to understand the reality. They are not responsible for the cleft, and they should not feel guilt about this process. So, throughout rehabilitation, from birth to adulthood, we observe different challenges. During school age, for example, we often support patients and families with situations such as bullying, learning difficulties, and social adaptation challenges. Some children talk, for example. They call me crooked-mouthed, smashed face. I don't want my parents to know about it because they will go to school and argue, and then I will suffer even more. Most of the time, when I identify bullying situations, we provide guidance to school through an official document. Some cases we also recommend psychotherapy to help the child cope with this experience. Next slide, please. During adolescence, there are other challenges. Some parents say, I don't know what else to do. We've done everything for her, brought her to Centrinho, gone through so many difficulties to give her the best, and now she doesn't want it anymore. So, sometimes during adolescence, patients no longer want to continue with surgeries. They may feel tired, and sometimes they expect faster results. Other difficulties we can identify at these stages are related to self-esteem and self-image. Some adolescents, for example, only take pictures from the side where cleft is not visible. Another very important and challenging use is very often is non-suicidal self-injury. For example, when I cut myself, I feel relief. All the pain I feel in my chest seems to disappear. In this case, it's common to identify psychological distress and psychiatric symptoms. Therefore, psychiatric evaluation and psychotherapy may be recommended to provide appropriate support. Next, please. In adulthood, we reach the final stage of rehabilitation, including procedures like orthodontic surgery, rhinoplasty. And at this stage, it's very common to observe high expectations regarding surgical outcomes. Some patients say, "This surgery is my dream. I will finally have the face I've always wanted, and the life I should have had if I had not been born with cleft." This can be very tense because sometimes patients see surgery as a solution for all their problems. Our role is to help patients understand the aesthetical and functional outcomes of surgery, improve self-image, and also support them within other aspects of adulthood. So, adulthood is usually more stable stage of life, but completing rehabilitation can still involve many emotions. Next, please. So, we have a lot of talents from birth to adulthood about the cleft rehabilitation. First is preventive practice, assessment and demystification of family beliefs regarding cleft lip and palate, to do psychosocial support throughout development, and development of protocols to assess patients' self-perception of rehabilitation, particularly prior to surgical corrections. Next, please.
Thank you. So next, what we are discussing is a very important part of this presentation. Patient experience can be a measurable outcome. So I know most of us are now inclined towards it. We started doing it in most of our practices, and there are scales fortunately available which are standardized, which was a major challenge in this area. Next slide, please. So when we look into patient experience as a clinical outcome, there are two ways of looking into it. One is to understand the domains per se, like the speech, the dental, or the hearing, etc., from the patient's perspective on how the outcome has improved. Now we see many patients, we asking them like, no, after, how do you feel after the surgery? They say, oh, it's great. But then sometimes as a clinician, we feel that, okay, it has not improved, or it is improved way more than what they expected. So what understanding their expectation and how those results are transforming into their daily life is something which we need to look into, since we are in many years into cleft care and most of our patients are grown up and functioning. So when we look into it, we know how far we have come. So prompts are basically domain based. So you can look into each domain and understand that. Whereas PREM, that is patient reported experience measures, is something which will help us understand how patient feels about the whole process of this care. So how much burden they are, how much accessibility issues they had, how much of inconvenience positive experiences they had. No, it is similar to you asking for a review from the patient on how you feel about the whole thing. So there are many ways of doing it. It can be simple short surveys or post-visit questionnaires. There can be emails, getting a review. Everything comes under PREM, but you can standardize it, and there are patient-reported measuring tools which will cover most of the areas, which gives us a complete spectrum of that experience and few things which the patient knows to tell. Next slide, please. So this is something which we think we are yet not there, but then sorry, go back. No, next slide. We need to do as per as we evolve and as we get into doing more of these practices. When the patient enters the cleft care program, so we have a multidisciplinary assessment and treatment, which is ideal. Then you have, once the treatment is done, you collect the prompts, that is the outcome measure. Then you collect PREM, that is their experience, analyze it, interpret it, review with your team, implement the quality improvement action. It can be simple as you want to do another camp in the place where patient is coming from, or it can be like reducing the waiting period, or it can be as big as changing the protocol altogether. Now, how does it work? You need to have a continuous feedback and quality improvement cycle. That is, you have to plan it, you have to do it, study, act, repeat. So this has to be ongoing. We need to decide as a team like how we would do it, and this will eventually get us into providing the best quality care for our patients. Next slide, please. Hibas. Thanks.
So we can use standardized assessment tools. Next, please. The strong example of standardized assessment is the Cleft Q. It's a free validation tool to examine patient-reported outcomes of the aesthetical, functional, and psychosocial aspects of treatment. It's available in 32 languages. The Cleft Q aims to capture discrepancies between technical outcomes and patients' subjective perception. For example, at Centrineo, we developed a research. The research was published in the Pellet Craniofacial Journal. The entitled Patient Report Outcomes and Surgical Correlates of Self-Perception in Adults with a Cleft Q study. As a main conclusion for this research, we find that reflect the cumulative impact of rehabilitation throughout life and highlight the decisive role of primary surgical techniques in treatment effectiveness, both in terms of functional outcomes and patients' subjective perception of their communicative abilities. So it's example the importance of the use of standardized assessment. Next, please.
CleftQ, as Dr. Hibas mentioned, is a great tool, Cleft specific. We have the complete spectrum of evaluation possible with CleftQ. So in our center, we have looked into the speech function, speech distress, and psychological function scores in 100 adolescents and adults with repaired cleft palate using CleftQ, and found that speech function and speech distress scores are correlated with the our functional outcome, that our outcome measurement, clinical outcome measurement. It was correlated to the clinical outcome measurement, that as the speech is bad, even the speech function and speech distress scores were poor. However, there was no correlation between the speech function, speech distress to psychological function, which indicates the psychological function can be more not maybe completely or more affected with speech. It can be the other aspects of cleft which would reflect on the psychological function. So apart from CleftQ, there are other tools which is available, which is published. So some of them are cleft specific, some of them are disease specific in terms of, see, for example, VILO is VPI effects on life outcome. This is VPI specific. So this is very sensitive to the changes after VPI surgery. And it captures the psychosocial and functional effects, which is not reflected in the speech measures alone. So these are validated and reliable tools which we could use on our daily regular practices. Next slide, please. So just for the audience to understand, there are other tools which exist. So we just listed out 3-4 which thought would be useful for somebody who want to look into. So one is the youth quality of life facial differences. So we have all the links for this coming up in the chat. You could note down from there. The pediatric quality of life inventory, which is so these are all questionnaire type, and then which is this specifically, one first is for facial difference, the rest is, the next one is for the entire quality of life inventory. Cleft hearing, speech and hearing appearance and speech questionnaire would be a great tool. Child oral health impact profile, so specifically for oral health, social well-being, and functional well-being. Thank you. Okay, so now we are going into the patient reported experience measures. So this is a small example. Next slide, please. A small example of how quickly you can assess the patient reported experience. So we have a mobile speech therapy unit, which is a bus which goes to the villages, and we have a speech therapy setup inside, and we provide speech therapy for patients at their place. So how we do it is we collect patients from a particular area where most of them report, which is like max like 250 kilometers radius, where we can go in and come back. And we go there, call all of them there, and have therapy process there. But we always had a doubt, like, how is it really helping them? Is wherever we are conducting the camp, wherever parking the vehicle, is that place accessible to them? Are they losing out on a daily income to just to come for this camp also, where rather they could come over to the hospital and see all of us there itself? So there are many questions as professionals we would want to see, like, to see if this particular program is working out. Should we continue with this program, the program benefits, etc.? So you see this area. So what feedback we looked for is improvement in speech and communication skill from the patient's perspective, satisfaction with the program structure, perceived benefits and overall impact, and suggestions for future programs. So there are some open-ended questions. There are some there's a Likert scale where they can rate. So you can see the sample a questionnaire here. So was the location of the camp convenient? So simple questions. Was the explanation of child's condition and therapy plan clear? Did you receive a home-based practice activity or follow-up suggestions? So this is to look into, like, are we providing enough? When we are going there, we can take a bus and go, but then are we really doing well by doing that? So next slide. Next slide, please. Thank you. So what did we come to know? So we know we were looking at, so we were able to understand the accessibility and convenience, quality of service, caregiver education support, and perceived outcomes, effectiveness, satisfaction, recommendations from their side, and future service use which the parents or caregivers would expect. Now, based on this, what we recommended that and that particular areas where we selected for this review. So we have taken 103 parents for this questionnaire, and we decided that we have to continue and expand the camp, add some quality parameters like a home training by like giving digital materials, etc. Post camp follow-ups, we understood that is not enough. They say we need one more. So we suggested doing online sessions after the camp, one session before the next camp, which was an add-on service quality. Increased frequency of group activities. Parents thought if you put them together in a group in the camp rather than individually, they do better, and provided home practice and resources. So the conclusion was implementing the suggested improvement could further enhance the camp's impact and reach. Thank you. Rihibas.
So, how can we support patient experience in cleft care? Next, please. I'd like to talk about patient experience in cleft care, shared decision-making, and informed consent. Patient family experiences can influence the entire trajectory of care. Successful treatment requires patients to develop coping mechanisms, which are behavior strategies developed to deal with challenging situations, such as undergoing surgical procedures. These coping mechanisms can be translated into great engagement and commitment throughout the rehabilitation process. So, informed consent and shared decision-making contribute to the development of positive coping strategies by promoting autonomy, understanding, and active participation in treatment. Next, please. Simple strategies can be implemented immediately by all members of the Cleft team. Motivational interview techniques can be useful tools to support communication with patients and families. For example, we can use open-ended questions. What do you think about orthodontic surgery, for example? Active listening. You are making great progress throughout your rehabilitation process. Summarizing, you are saying that you have high expectations regarding rhinoplasty surgery, but at the same time, you are afraid what the end of the rehabilitation process will look like, and then change talk through selective reflections. How could following the dietary recommendations help you during your recovery from surgery? These strategies can be especially useful before surgical procedures. Next, please. In our experience, you can use different tools according to the patient's age. For young children, for example, we use place-based tools like to reduce anxiety and help children understand the treatment process. Examples include the doll, the 9 reasons for a smile, the course certificate, and Playmobil activities. These methods are used for psychoeducation and support emotional preparation for procedures. With your older children, we focus on normalizing their experience, validate their challenges and fears, and introduce positive coping strategies. At this stage, we can use other tools, such as pictures and other visual results. Next, please. With adolescents and adults, we use more cognitive-based approaches, include psychoeducation, shared decision-making process, mindfulness strategies, and emotional validation. We can work on improving expectations and assessing behavioral skills related to positive care recommendations. The goal is not only to prepare patients to surgery, but to support their emotional development throughout the entire rehabilitation journey. Next.
So thank you very much to all 4 speakers for some excellent presentations on this really important and very challenging topic. So we want to understand a little bit more about the challenges you face in your daily practice. Again, this poll is anonymous, and although there are many challenges, we want you to choose one of your greatest challenge. So what is your greatest challenge in collecting patient-reported outcome data from patients and families? And you can select one of the many answers available. I know some of you may think, I certainly thought, well, all of them are challenges, but if you can tell us what the biggest challenges are. And then what is your greatest barrier to assessing patient experience in your Cleft program? And the last question, the third one, which aspect of patient experience would you most like to strengthen in your Cleft program? We'd love to hear your views on these 3 questions. How are we doing, Darcy? Oh, wonderful. So it looks like lack of time is the greatest challenge. That certainly resonates with most of our audience. And the greatest barrier, you've got a bit of a tie there, limited time, lack of patient-reported outcome tools. Hopefully today's webinar has given you some solutions to that challenge. And of course, difficulty in following up patients long-term. And which aspect of patient experience would you most like to improve? That we've got a clear winner there, overall quality of life, which is really what everything is about, isn't it? Second to that comes satisfaction with surgery, but overall quality of life, more than half of us thought that was the most important. So thank you for responding there. We've now got a panel discussion ahead, and it's going to be moderated by Professor Adeola Olusoya, and she is a maxillofacial surgeon with a special interest in cleft speech outcomes. She's been working with individuals with clefts for the past 18 years and offers her services in the southwest part of Nigeria, She also serves as the president of the Pan-African Association for Cleft Lip and Palate. Professor Adiola.
Thank you, Dr. Mahendele. We must all agree that this has been a very wonderful discussion from all our panelists. So I say thank you. And also thank you to SmartRain for giving this opportunity to have this unique discussion amongst different specialties in cleft care and to come to this roundtable and give this discussion. So I would want to go to the panel discussion by asking a number of questions. Afterwards, the plan will be opened for questions from the audience. But our panelists, if you don't mind my asking you a few questions, let's start with Dr. Krishnamurthy. When we talk about successful cleft care, clinicians often focus on surgical or functional outcomes, but the experience can look very different from the patient's or family's point of view. Can you share just for a moment where your assessment of a good outcome did not exactly match what the patient or family experienced, and how did that shape the way you approach care? Dr. Krishnamurthy, please.
Thank you. Thank you. I will give a couple of examples from my own experience. Like my colleague Aparna mentioned, we have patient experience measuring outcomes, or the PREMs. Incidentally, PREM in Indian language is love. So we did a survey of 100 odd patients on whom we did nasoalveolar molding on parents, the experience of undergoing nasoalveolar molding. Almost 100% of the parents agreed that they would recommend this or they would go through the process again. However, there were two very important part of the experiences which was not so good. One was the number of times they had to travel all the way, come and wait at the hospital and get this treatment procedure done. They found that difficult. And also for the newborn baby on whom we did nasoalveolar molding to be able to get used to the complicated appliance that we used. So overall, we thought it was successful. They thought they would go for it. However, there were significant points. And I think the kind of advances that are happening in aligners, technology, etc., will hopefully make both of these problems go away, and everybody is working on it. My second example is from treating noses. Many of the children as they grow up are not worried about their nose, though we saw examples of how it can affect them. But when somebody gets affected by it and requires a surgical therapy, oftentimes immediately after the surgery, in the first few follow-ups, both of us, the surgeon and the patient, agrees that the result has been good. But many of these people come back sometime later, a year or two later, who now have different other problems that they never recognized. We have to be aware that those who are having problems because of their appearance are unlikely to be completely satisfied. And what is the lesson that I've learned? This is something that has been taught to all of us time and again, is to make sure that the expectations are not raised to a great extent, and also make use of your psychologist in helping them cope. This is something that Dr. Hibas very, very clearly showed in a slide. It is impossible for us to create perfection, however much we might try as surgeons. The most important thing for the child or the parent is to be able to cope with it, understand how this with whatever you have, you learn to live a normal life with that. So this is something I think we need to seriously emphasize, that providing psychological support to not only the patients but also the parents when they first come to us should become a top priority wherever we are in the world. I know there are handicaps to that, but this is something that is an urgent need for most situations.
Thank you, Dr. Krishnamurthy, for that insight. We would agree that loss to follow-up is a common phrase amongst us as practitioners. So my next question will be going to Dr. Apner. long-term follow-up is essential for understanding our treatment outcomes, as you have so wonderfully shown us. Yet, many programs face challenges in managing patient engagement. How has loss to follow-up affected your ability to evaluate outcomes, conduct research, or improve care at your center? And what strategies have been most effective at your center for maintaining long-term follow-ups and capturing meaningful outcome data? Dr. Abner, please.
Thank you, Dr. Lasania. So this is a very important question, and I think it remains a significant challenge for most of the cleft care centers to have their long-term outcomes being measured. So it is important because it is going to validate if our treatment protocol is actually serving what it is supposed to. So it really validates the existing protocols. So at our center, for instance, we have attempted looking into our 20 years follow-up to see how the outcome of cleft palate protocol was. So the intention was to look into the growth and the speech outcome in a 20-year-old patients. But of course, no, the follow-up rate was very less, and we had to measure outcomes on those who were engaging with us with our unit and frequently following up with us. So basically, it is not the representation of the actual cohort. So though we like to believe that the ones who have not come back to us are doing very well, or they are waiting for their the quality of the improvement in quality of their outcome. We don't know. So this shift our focus from how good our outcomes are to whose outcome we are actually measuring. Like, we are measuring the outcome of the ones who have come to us, which is not actually giving us the real result. So we overestimate or underestimate our outcome based on what we measure there. Now, how are we improving it off late? Because the digital technology is helping us. So we are engaging them more with online consultations. The ones who really can't make it, we insist they you connect online and speak to us. So we assess them online. We have try to maintain the database. We explain to them in the first go itself how their treatment continuum is going to look like. Even if they are doing very well, how subtly we can pick up smaller problems and correct it. All of this information is bombarded to them in the first go. I think all my teammates are reiterating on it. That makes it very easy for us to maintain the follow-up. Still, I would not say that it is good enough. Thank you.
Thank you, Dr. Apna, for that. So our next question will be going to Dr. Hivers. Are there any recommendations or approaches you would suggest to other teams facing similar challenges with follow-up?
Thank you, Dr. Adela. Yes, I believe one of the most important recommendations is to adopt a patient-centered approach from the beginning of the treatment, and all the team can do this. Building a trusting relationship with patients and their families, providing clear and age-appropriate information, actively listening to their questions and concerns. All of this can improve engagement and long-term follow-up. Even teams without a psychologist, because we have teams without this professional, healthcare professionals can make a meaningful difference by using effective communication strategies, encourage shared decision making, support informed consent, and before a surgical procedure especially is very important. Another important point to explore is the patient's expectation and emotional responses throughout rehabilitation, especially before major surgical procedures. Simple techniques such as reflective listening and using open-ended questions, all of these things can help identify concerns, strengthen adaptive coping, and promote great commitment to rehabilitation.
Thank you, Dr. Hibas, for that. If I may add, looking at the psychosocial and emphasizing on the social aspects of the patient care, such as having get-togethers whereby the specialists are actually the volunteers. Those in my center we found to be really wonderful. It helps with patient engagement. They tend to see the human aspect of the care providers. So that may be another way to look at how to hold on to, keep them engaged and let them keep follow-up. Thanks, Dr. Hebers,
Yes.
for that insight. So I would also want to call on Dr. Russell Percy. Many Cleft teams know they should be measuring a broad range of outcomes, and there are varied outcome protocols and measurements that we can use. But time and resources, as we have just seen in our polls, are quite limited. How do you decide what to prioritize? And is there an outcome you think every Cleft program should be tracking? Dr. Percy, please.
Thank you for your question. This is an interesting question, and I think that, as I presented before, we have two main questions to be answered. First, when the outcome should be measured. I think there are critical points during the lifetime of patient. There are critical points, and these points are situations when you can measure better the outcome, which is the lip surgery, palate surgery, a bone graft, and the adult. At least these 4 points. I think that it is important. This is basic information that can be achieved easily. Second question is how. This question is more difficult to be answered because there are many ways to measure an outcome. And I can say, well, the best way to evaluate a lip and nose outcome can be facial scan, 3D facial scan. But this is not accessible for all centers, of course. In that way, that should be considered, in my understanding, is to use an instrument, validated one, available for that center to measure the outcome, to validate that measurement. I think this is extremely important. I think that the quality of the outcome is not the only thing that should be evaluated. Also, the quality of the center should be considered. In this point, the follow-up is extremely important. And my final comment regarding your question is that the best way to get a proper follow-up is providing good outcomes. Believe me that the patients are coming back when you are doing the things well. That's my comment. Thank you.
Thank you, Dr. Russell Perry. That last statement is very apt. It's very, very apt. So we're a bit short on time. So I would want to invite the panelists, if you can just use less than a minute each, to reflect and give us your thoughts on how you can share a specific example where outcome data, whether clinical, functional, or patient-reported, has led to a change in how your team works or how care is being delivered. Just less than a minute. Can we go, Dr. Krishnamurthy, please?
Yeah, so I will take less than a minute. Before I answer these questions, I want to join issues with two things that I was told. I couldn't agree more with what Dr. Hibas has spoken. I would strongly emphasize on what she said. And as far as collecting data is concerned, one of the biggest drawback is our own attitudes. We need, however difficult it is, we need to decide that it's possible. Now, coming to this example, it is my experience with managing the primary nose. I've gone up and down doing closed reduction, closed rhinoplasty, open rhinoplasty, nasoalveolar molding, doing nothing in my career. And we have looked at results when we were not doing anything to the nose. And we have published this as a comparison between patients who underwent nasoalveolar molding and those who did not undergo nasoalveolar molding. We found excellent results on our bilateral lips with nasoalveolar molding, but the nose were the same, both whether we did nasoalveolar molding or not, when we were not doing any primary surgeries. And I was very clearly told at one of the Smile Train presentations that not doing anything on the nose this day and age is not something that is welcome. There's so much of data and pressure, and now I do semi-open rhinoplasties for all my cases. We use conformers. I don't have long-term results, but it appears that I have taken the right decision by the time I reach 60.
Yeah, thank you, Dr. Krishnamurthy, for that. Dr. Apna, same questions, please.
Thank you. I would like to mention about the speech summer camp, which we have been doing in our center for so many years now. And I was expecting that this is short-term intensive camp, and we are doing a lot of drilling, parent training, etc. And the outcome is going to be excellent, which was actually excellent immediately after a post-op assessment showed that they have learned what they had to learn, and we were successful. But then we left them saying that, okay, let's see, 6 months, let's not do anything, because parents are trained, the kids are trained, let them do it at home. And 6 months they come back, the results are the same. They have not improved any further, and the 6 months is lost. So this was a learning where we understand that a short-term intensive may not replace a continuous learning, and we will have to be careful of the method which we adopt and think which is right, which may not be actually. Yeah.
Thank you for that, Dr. Apna. Dr. Hibras, please.
Yes. So at St. Reno, you have an example with our multidisciplinary craniofacial team. So you have a speech pathologist, social work, psychologist, surgeon, genetics, all the team working together. And all the patients are evaluated by the entire team before a shared decision making process, particularly before surgery procedures. So you attend in individual, but after we discuss the case and after we share the decision with the patient. I think it's a very great experience and it's easy to implement. To specific psychosocial outcomes, the next step we intend to implement it is use of the Cleft queue systematically, but we
All right.
doesn't use it. We only use it to research.
All right.
Now.
Thank you a lot, Dr. Hibas. Dr. Percy, please.
Thank you. And at this point, I like to get the chance, if may I, to answer in the way of the burden of care. I do believe that the burden of care is in direct relation with the quality of the treatment we are providing. I am extremely surprised how many treatments are adding day by day, month by month, by different specialists, creating an increasing number of interventions provided to the patients. I do believe that the more is not necessarily more. Sometimes more is less. This point is critical. I've been looking pre-surgical treatments, post-surgical treatments in different fields. That this is not demonstrated or proved, but by well-designed research. So this is critical. If we have to talk about quality, we should consider that the treatments that we are providing should be well validated to be used, because this is not happening. And the patients is suffering, Mariani probably is considered very well this, is suffering stress. A surgery is a main stress. So if we are adding pre-surgical treatments in different fields and adding to the surgeries, believe me that this baby is receiving a lot of stress, and probably the impact cannot be evaluated in short term. Probably we know what happened in long term. So,
Okay.
so
Yes.
I think we should consider the burden of care very carefully. I agree with Dr.
Very true.
Krishnamurti in his comments.
Very true. Now, our time is really, really fast spent, and we'll actually maybe 1 or 2 questions from the audience, if that's possible.
Yes, please
Does
go
anyone have
ahead.
any question on the chat?
We have one question, which is, we have a few questions. One that I'd like to highlight is, how do we compare the successful outcomes defined by the specialists with the expectations of the patient? If the results are not the same, the outcome of the clinician is one, but the patient reports something else, what do we do? Dr. Krishnamurthy?
Yeah, so what is important for us is to understand where we have gone wrong. Because so many times we are thinking differently. I'll just give you an example. This morning, I was doing a bilateral cleft nose. I just went in and asked the patient, what does he want? And then he just showed me the tip of his nose and he said, this has to go up. Meanwhile, one of my colleagues intervened and said, give a list of problems that he think needs to be fixed. So therefore, it's important for us to understand the needs of the patients, see whether those can be addressed, particularly when a lot of this is related to the appearance of the patient, their psychological makeup, etc. Also, if I can quickly, while I'm at it, answer what Percy said about burden of care getting added on. I have absolutely no problem in agreeing with him. It is important to reduce the burden of care. It doesn't mean that we have to give up interventions, but there are various other ways of doing it. For example, I have colleagues who do lip and palate surgery together. All of us are doing it twice, once at 6 months. And why? Why don't we do it all together at one stage? Nothing is going to change drastically, as you mean, in the long run. So there are areas we can identify where the burden of care can be significantly reduced without giving up any useful interventions. That's my answer, Dr. Percy.
Thank you, Dr. Krishnamurthy. Do we have any other question in the chat? I think
Another question was, are there specific ages at which outcome measurements are recommended so that we can capture the entire picture rather than outcomes in specific domains?
I'd like to answer that question, please.
Please.
Is that possible?
Go ahead,
yes,
please,
please.
Dr. Percy.
Okay. There are different times, as I presented in my slides, but I believe there is a critical age. The critical age is the preschool age, because the main impact, which is the patient is receiving, is during the school time. School time is hard because other children are cruel and they don't understand very well to what is happening, and they are bullying the patient with a cleft. So that we have to consider is that the patient should be in the best condition. In that way, I disagree with Dr. Krishnamurthy. Patient should be in the best condition to be ready to the school age, which means aesthetic and functionally. Sometimes the patient has difficult fistulas in palate, or maybe the nose, or some critical areas to be corrected. And these problems are usually delayed. I have patients, I've seen in office, 20 years old, 30 years old, living with a bad speech or living with a big fistula in the palate because other physicians, other professionals said, oh, this cannot be corrected at an early age. And this is a critical point. I think we recommend that we should correct all these points before the school age. And the answer is that if there is an age to be considered to get the best outcomes as possible should be the preschool age because of the impact, psychological impact. And remember, a surgical problem can be corrected, but psychological problem probably could be more difficult to be corrected. That's my
Thanks
answer.
a lot. Thank you a lot. Thank you so much. Thank you to our wonderful panelists. Thank you for the very active discussion session. And I must say that we need to give a shout out to SmileTrain, being a very unique organization to actually put this together. It has been a wonderful period to discuss several specialties coming together and also showcasing that there is life after the knife. There's a lot of life after the operation, and there's a whole lot more that makes a human being than just the clefts. Thank you so much. Over to you, Darcy.
Thank you all. This was fantastic. Dr. Olusonya, I could not say it better. There's life after the knife. I love that. Thank you all so much for joining us today. A huge thank you to our speakers for sharing your time and expertise with us. And a big thank you to Dr. Mahandale and Dr. Olusonya for facilitating such a smooth and effective session. We have one last Zoom poll that I will be putting on the screen to get your feedback on the session. You will also all receive a link to the recording of the session and have an opportunity to make suggestions for future Grand Round topics. We look forward to having more sessions in the future and having you all join us. Thank you all so very much, and we look forward to seeing you there. Have a great day, everyone. Thank you.
Thank you for the opportunity. Have a nice day, everybody.
Bye.
Thank you, Darcy and team.
Bye-bye. Thank you.
Bye-bye.
Do fill in the poll.
I'll keep the poll up on the screen for a few more minutes for those who can join. If you need to sign off, please go ahead.